Great. Great. Well, it's lovely to see you all this evening. Thanks for taking up some of your time this evening to learn and to be able to share your thoughts on this really important subject. So everyone will be aware that the NHS is under. Oh, I'm introduced myself. I did on the chat, but I'll do it again. So my name is Dr. Ben Allen. I'm a GP. I work in Sheffield. I'm a partner at GP Surgery, and I'm a clinical director for primary care across Sheffield. And really passionate about how do we give the best care that we can with the resources that we have. And this is a great talk along those lines. So everyone will be aware that the NHS is really stretched, general practice is really stretched, and particularly vulnerable people who maybe aren't able to speak up or have lots of healthcare needs often can lose out when when those kind of scenarios happen. So we need to be able to think differently. You know, we've got to be able to offer great care. Lots of people say we just need more doctors, we just need more money. But whilst we're waiting for that to happen, if it's ever going to happen, we need to be thinking, okay, what can we be doing now? What are some of the ways that we can be working differently and thinking differently that can mean that we can be all offering the care that we really want to be doing. And this is today hopefully be a really great story of how some people have managed to do that hopefully we can all learn from. So we'll start off with so Kristian from Vanguard is going to talk a little bit about systems thinking and failure demand and talk about some of the theory, and then Liz, who is a nurse care coordinator, and there's some real great stories around how people with often vulnerable people who got complex needs, often in hospital a lot, often have lots of different people involved in their care, often quite disjointed, and some of you will be well aware what that's like and what that might be like for the people on the receiving end of that kind of care, thinking how do we do that differently? How can we do that better? And there's some really great stories from that. And then Darren will come up next, talking about some of the themes that were found and what the impact that's been, what that impact that's had on demand. Then we'll have 15 minutes for questions at the end. I think you're welcome to put questions in the chat as we go along. It might be helpful if there's a question that you think that I'd really like that question answering. If you like it, then it gives a bit of a sense about which are the questions that you most want us to be answering. So I will, and today's been hosted by Q's Primary Care Special Interest Group, which is headed up by Ramya, who you may be able to see on your screen. So should we start with Kristian?
Perfect. Thank you very much for that nice introduction, Ben. And good evening, everyone. And thank you so much for spending a bit of your Wednesday evening on this, what we believe is an immensely important subject of changing the nature of demand by improving the NHS as a system. Now, I don't know about you guys, but I find that a lot of people within healthcare at the moment are talking about this need for a personalized care model where the patient is at the center of everything that's done and where care is tailored to the individual and where continuity of care is in focus. And I believe that all sounds absolutely brilliant, but I've caught myself kind of asking myself, why is it not a given in a sector where you know, it's as personal as in healthcare? Why is there a need to stress personalized care? And when you look into it, it's actually not a new message either. I found these nice guidelines back from 2012 that very clearly states what it means to deliver personalized care and what we should be aiming for. So maybe the question should be instead, why are we still talking about personalized care? Or more importantly, what are the causes within the NHS that's preventing us from working in a way which from the patient's point of view is experienced as personal? So those are some of the questions which we have tried to tackle at the primary care network K2 Healthcare, where Darren and Liz are from today in Lincolnshire. And we're very excited to be here to share our learning with you guys today. So I'm Kristian Astrup Nielsen. I work for Vanguard Consulting, and we've been leading with the Vanguard method with K2 Healthcare. And I will kick us off by taking you guys through the perspective behind the Vanguard method, which is based on understanding and changing organizations as systems from the outside and in. And I'll talk a bit about what that means. This is very important because the transformation that we've been doing with K2 Healthcare have been focused on this method or this perspective, if you want. And it kind of positions failure demand, which some of you might have heard about before, as a systems concept and not what you could call a transactional event. Failure demand is one of these elusive ideas that's very easily understood, but as easily misunderstood. So I just want to make sure that we get it right today. And after that, Liz and Darren will talk you through some of the more practical details about the transformation and also present the results in relation to patient care, employees, and costs. Cool. But I just have a few slides to help me on the way. So let me just bear with me while I pop these on. I just want to take a bit of time just to talk to you about what we mean about this outside-in systems view. And there's a couple of questions that help you take an outside-in perspective on your organization. The first one is, who are we here for? You know, who are the customers that we're here to serve? And from their point of view, what is the purpose of our organization as a system? Now, if you find the answers to these two questions, you'll find that these are quite stable, but can evolve over time. The third question that helps is more focused on the individual. So within the NHS, the individual patient, and understanding what's the individual need for care and what matters to the individual when that need is met. And if you go out and study this, you'll learn that there's a very, very high degree of variation across the patients that you look at. Now, the next question then becomes, so if we understand the customer, who the customers are, what the purpose is, what need and what matters look like, how well do we then as a whole, as a system, meet these 3 points? And I'd like to try and tell you what we've seen typically happen and kind of illustrate some of the big problems that we've seen within organizations as the NHS. So I'm just going to pop the customers or the patients out here to the left, along with purpose, need, and what matters. So the first thing that typically happens is that a new need or a changed need appears from the patient's point of view, and that generates this value demand. So a value demand is a demand related to our purpose as an organization. And that value demand then enters the organization. So this dotted line you have on the screen here, that's the system boundary, if you want. And at this point, something really, really interesting happens, because this one patient, one demand is being converted into a long range of different tasks to be carried out. And why does that then happen? Well, it happens because we tend to structure and organize ourselves in these functionally specialized structures, and then we place a top-down hierarchy on top of that. And what characterizes an organization like this is that the roles and responsibilities within each function are quite limited from each other and focused on just one specialism. And the reason we've chopped up the customer in all these fragmented parts is that it makes it easier for us to disperse each specific task into that part of the organization that deals with that specialism. So what happens at this point, and why this is so important, is that this is where we kind of start to lose a little bit of focus on the customer or the patient as a whole, if you want. Each specialist bit within the organization tend to view the patient from their own specialist lens. It's the case of no one knows or does everything, but everyone does a little bit of their own special something, if you want. And what we then do within each functional silo is that we assign them individual budgets, protocols, procedures, IT systems, targets, service level agreements, standards, responsibilities, and so on and so forth. And these all look different if you look across all the different functional specialized bits of the organization. So what do managers then pay attention to in a system like this? Well, they tend to pay attention to achieving low cost. We have an obsessive focus on achieving low cost through economies of scale. We focus on achieving efficiencies through standardization, standardized work. We make people follow procedures and protocol because we have an idea that that's going to lead to a high quality of the work that we're carrying out. We focus on leading by KPIs, targets, reports, and we pay attention to best practice pathways and protocols. And then in relation to quality, we focus on achieving quality through inspection after the work has been carried out. So I don't know if you recognize what I've kind of described on the right side of the screen here, but what we've seen in a lot of different types of service organizations and also the NHS is that this is quite normal stuff. And if you get interested in understanding where all this stuff comes from, well, a lot of it comes actually from the early days of manufacturing. And that's all well and good if the task at hand is to produce 5,000 pens like this one and make them all look exactly the same. But when we're in a situation where there's a huge variation in what the customers look like, what their need look like, and what matters to them, then these types of operating principles can cause some problems. So the big question becomes, if we put the customer or the patient back together, that could be a job in itself. But if we manage to do that, the big question then becomes, what does this look like from the patient's point of view? Because typically when the patients have been dispersed into this specialized organization, we don't really know what the end-to-end experience look like from the patient's point of view. But what we've learned in practice is that some of the consequences of this way of managing and designing healthcare is that things take quite a long time end to end. Now, we might be very, very efficient in carrying out tasks, let's say T, O, and R, but when you look at all the tasks from C, customer, all the way down to R, then the end-to-end time seem to be quite long. What we also see is that there's a lot of different professions involved. The patients see a lot of different people, have to explain themselves a lot. They experience a very episodic and transactional service. And we see a lot of duplication of work within the organization, simply because there are so many different professions involved. So lots of transactions, lots of referrals, lots of documentation that's lost or just, you know, it might not be lost, it just can't be found. It's there somewhere, but we can't find it. We provide the wrong care in relation to the individual need and what matters. We miscommunicate, and from the patient's point of view, there's no or very little continuity in the relationship that we have with the patients. So what then happens when these, you could call them organizational dysfunctions or types of waste or whatever you want to call it, when they're experienced by the patients, well, that's where the value demand then is being kind of turned into failure demands. So failure demand is always related to a previous value demand that has come into the organization. But because of the way that we've handled the initial value demand, it generates failure demand. So the initial value demand I need help with could lead to failure demands like, why have you not helped me? You did it wrong, or my problem has got worse. The other value demand, my need for help has changed, could lead to failure demands like, why have I not heard from you? It's not working. I don't understand. And the other value demand, my circumstances have changed, could lead to, you still haven't corrected. Where are my letters? You got the wrong information. Now, what our learning in Vanguard is across a multitude of different service organizations is that the volume of failure demand can range between 40 to 70% of the total demands that come into an organization. Now, just take a minute just to reflect on that, on those numbers, because that is quite significant. Because what happens, a failure demand is not just a transaction, it's not just a contact that comes in, it's a consequence of something that's not been done or not done right within the organization. So you can't fix the failure demand by focusing on it. What happens with the failure demands is they enter the organization exactly the same way as the value demands, and then it's being handled the same way. We split it into a range of tasks and we disperse it into the organization and handle it that way, which then again can lead to additional failure demands. So we kind of end up in a situation where we have this kind of perpetual cycle of like a vicious cycle going on, if you want, where we have lots of referrals, but no one is fixing the real problem. Patients are being sent from place to place. They are experiencing a very episodic treatment, no continuity in the care. Patients don't get the help they need. They get worse. The backlogs increase, the waiting times increase, and so on and so forth. And if you had to summarize this, well, what we've seen is this is consuming huge amounts of resources and thus costs. It's also creating a very stressful work environment for everyone involved, and the consequences for the patients is, well, it's quite a poor patient experience. So let me just stop the slides. I hope that kind of illustrates very, very briefly how we view the world. So if this is the challenge, and you might agree or you might disagree, I almost hope you disagree a little bit, because then I could ask you to go out and study it yourselves, and you could maybe learn whether I'm right or wrong. But if you believe me for a second, and we're saying that this is the challenge that we're facing, then how would you then go about improving and personalizing patient care in a system as big and complex as the NHS? And what we've learned is that you wouldn't want to try to redesign the whole system at once, because this would simply be like trying to boil the ocean. Instead, what you need to do is get as close to the patients as possible in their locality. So really take this outside-in perspective, start as close to the patient and start building something different from there. And then you need a structured and methodical approach with a firm focus on the individual patient's end-to-end care experience, if you want. So this is exactly what Darren and Liz have done with the Vanguard method. They've applied the Vanguard method to understand and improve the system which delivers patient care to the frail elderly population. So that's where we've started. Doesn't mean the learning can't be applied elsewhere, but that's just where we've started. And they've done this with a patient-centric point of view. It's a journey that starts by studying the current system to understand the degree to which these problems that I've just outlined earlier, how they consume capacity and cause poor patient experience. And when you then learn about both the symptoms like failure demand and the systemic causes like the highly functional design, then you can start to do something different from a more informed basis, if you want. So Liz and Darren, we've not completed the transformational journey yet, but we've designed a new approach to patient care, which already has led to some quite remarkable results. And I'll save all the good bits, all the exciting juicy bits for Liz and Darren. So I'll hand over to you now, Liz.
Okay. Hello, I'm Liz Reader. I'm a nurse of 30 years experience in the community, and I work with complex cases, young and old, or over 18s, I should say, in the community to try and improve outcomes and prevent readmissions. Really is my framework. So I'll just share my slides. Can we all see? Yeah. So I was asked by Darren to be involved in could we work in a different way, and to talk with Kristian regarding the Vanguard method. Initially, I thought I've been doing this job now for umpteen years and I know my patients really well. I'm doing a really good job, so I'm not quite sure what Kristian's going to do for me, but I'll go along with it to see what he has to say. So initially, Kristian sort of said, well, we're going to look at the experience of healthcare from the patient's point of view. So he asked us to look at the initially, we were asked to pick a patient from my caseload to look at the purpose of the project was to design the care around the patient, what matches the life context, so that the patient can live a good life and die a good death. What we're focusing on is what absolutely matters to the patient and what is the need. So we started off our journey by picking one patient, and as you can see at the bottom of this slide, this is one journey of a patient that we mapped. And we initially started off by choosing a patient at random, really. I was referred a lady the day before Kristian arrived, a daughter saying, can you help me? My mum's just about to come out of hospital after another fall. She's due to have cancer surgery in a week's time. I'm frightened that she's going to come home, fall again, and that's going to delay her treatment. Can you do something different? So we chose her randomly. We then began looking at her health journey, going back to almost when she joined the practice, which was a good 20 years ago. We mapped this lady in detail initially to every intervention, every blood test, every phone call, to try and understand from her point of view her health journey over the last 20 years. I was horrified by the repetitiveness, the lack of continuity, the amount of times she would engage with the surgery, and yet we'd see, treat, discharge, but nothing. The computer system we use, System 1, to find anyone's history, you have to scroll through. It's really difficult to get a picture of what's going on. But this enabled me to look at the whole of this lady's journey. I could then see, actually, for this lady, she started falling 11 years ago when she lost her husband and her confidence started going. I could then see that actually every time she's falling, she's ending up in hospital, calling an ambulance. I then went into a bit more detail to find out, well, what time are you falling? Is there any pattern in that? And we found that, yep, she was falling at night, overnight. She was an 84-year-old lady by this point, living on her own, a supportive daughter, diabetic, knew the district nurses really well. I knew her really well, so I thought I'd been in there over the years, and I'd seen, treated and discharged her when we thought we'd patched her up and got her better. So I initially, with this lady, we now understood her journey. I then went to visit her to understand from her point of view what mattered to her, and if what she wanted from me. Could we look at the healthcare system that we are providing in a different way? I could see that she'd had 50 days plus in transitional care, having extensive therapy. She could walk those 10 meters and then we discharge her back into the community. We increased a care package. We put in a bit more equipment, all these standard services that we would do for our patients who fit the model of needing therapy following a fall. But it wasn't stopping her falling. She'd fallen 16 times in the last 11 years. So we had to look at trying something different. And it was only listening to her, and from her point of view, she was frightened. She was fearful that she was going to fall again, no matter what services we put in during the day and how much physio she had. It wasn't enabling her to prevent those falls. What she wanted, and she felt safe and secure, was in a care home. She did end up long-term in a care home after I was able to challenge the authorities because she didn't meet the threshold for social care, but I was able to argue on her behalf to say we've got to try something different. And since she stayed long-term in the care home, she's finished her cancer treatment. She's not had a single fall, and she is absolutely a different lady. And she's no longer using systems to prevent and to manage falls. So we looked at once we'd got the purpose of understanding what matters to the patient, we looked at the methods. So we looked at what matters to the person determines what we do and how we do it. And there was a high degree of continuity of care. So I took ownership of a group of patients, so they had that high level continuity of care. We looked at how I was going to manage the flow of my workload. So I understood my patients really well and what mattered to them. We looked at the right care for them. We looked at how we carried out the plan, and then we reflected, was it working? The project had only three rules for the time I was doing it, which were really good. Do no harm, don't break the law, and we weren't going to change the IT yet, because we recognise that the IT that we work with sometimes is a bit of a hindrance and it doesn't help. So that's the next part of what we're looking at. So where policies get in the way, referral criteria, I get so frustrated that I'll refer to a service, but the patient doesn't tick all the boxes, therefore they won't take ownership. The policy says no, therefore we can't do for you. So I had to be a little bit creative on actually looking at those policies and challenging where we could make a difference to get a different outcome for the patient. I then looked at another patient, I'm going to call him David. Now, David was a 65-year-old diabetic. Came into me, few people had said to me he was quite aggressive, he was poor eyesight, he was non-compliant, so I don't know why you're bothering, really rude, and he's a really heavy smoker. You're not going to make a difference. So I began to study him. I didn't go into as great detail with him on the day-to-day, but I looked at themes of where things are around his diabetes. So I looked at his HbA1c level, and I was quite curious at why his levels were going up and down. In June 2020, as you can see, they were horrendous at 185. What had happened at that point? I picked him up at April 21 when his HbA1c was 108. Diabetic specialist had been heavily involved, and that had reduced his HbA1c in 2019. He was then discharged. You're doing really well, you can self-manage, you don't fit our criteria anymore. Then the pharmacy did their review, and they found out that he'd actually stopped taking his insulin in 2020. By this point, he was fed up of being told what to do and the way to live his life, so he wouldn't engage with anyone. And then I was asked to pick him up. I went to meet David at home and to try and understand from his point of view what he wanted me to do and how he wanted me to help him. From his point of view, all he wanted was cataract surgery. The surgeon wouldn't do his operation because his diabetes wasn't managed, and he couldn't see that we needed to support him with his diabetes to enable him to get his surgery. So because he had a purpose in mind, that was our aim and our goal, to try and work towards getting this surgery. He was then fearful of self-injecting. He had really bad neuropathy, and giving himself the injections was really painful, and I really struggled initially to get him to engage and have that his insulin. We finally managed to convince him, let's give it a go, because if we don't, you'll be dead in the next year or so. We then managed to get him the support tailored around what he wanted and getting him engaging with us. And as you can see, his HbA1c levels dramatically came down once he was getting the insulin that he needed. That was initially by district nurses having to visit twice a day, which in the past we'd always told him at 65 you need to self-manage your own diabetes, but he's continued to this day, got the diabetic nurses or the district nurses involved. He's had bilateral cataract surgery, and he's a much different, healthier gentleman than he was when I first met him in April 21. At times we still have problems with his rudeness and aggression, but I know him really well now, and I'm that level of continuity that when we have trouble with district nurses and flare-ups, I'm on a good rapport, and we're able to manage and support him.
Last couple of minutes, this one, Les.
Okay, so again, Kathleen is the same sort of scenario, 9 admissions, 9 ambulances in the last 8 months. Again, it was looking at any themes, any patterns, what mattered to her, to try and tailor her care around. So all the cases I've been involved in are all different, whether they're mental health, whether they're, diabetic, COPD, It doesn't matter really what the issue is, it's understanding and challenging the traditional services and the policies to enable us to get the care that the patients need and want. And I have found that that has dramatically reduced the GP's time, because they no longer keep phoning the GP for silly little things to try and get noticed, because they know that they contact myself, or I'm in regular contact and support. I'll end it there.
Thanks, Liz. Hello, everyone. I'm Darren Altus. I'm Director at K2 Healthcare. We're a group of federation of 16 GP practices in Lincolnshire, about 130,000 population. We look after 2 primary care networks within our practices. Care coordination. We've got a team of Liz's that's been fundamental to our neighbourhood working for a number of years, and we brought Vanguard in to have a look at that from a systems perspective, as we've seen today. I'll just share my screen.
If you're thinking of questions whilst Darren's just doing that, as these are going forward, you can pop them in the chat, because we'll have a 15 minutes questions in about 10 minutes.
So I'm going to talk a little bit about the general themes that we found from the experiment that we did, and the effects that we saw on the demand to the system from the changes that we made, and then a little bit about the next steps for us to carry the work forward. So what we found is that understanding the person is a critical factor, and that involves, as Liz said, researching clinical record in detail and over time, talking with the person and their family and their support network, and taking that time to truly understand their circumstances, understand what's important to them, which has always been the first step of the work that we've done. Trust is key to that change. So we found that just taking that time to understand the person and listen to what matters to them has had a profound different and positive effect on them, just knowing that we've spent the time to have a look, have an interest. So that lets us build a relationship of trust with them, and then they trust us to try something new and to work together to improve things. But them just knowing that we've spent that time to have a look into them and understand them has made a difference just in itself. Again, continuity is critical. This doesn't mean someone doing everything, but someone that's along that journey with them. Of course, we want to make the most of the assets that we've got in our neighbourhood, and of course, working with partners has been at the centre of our attention, and introducing new roles through the roles scheme like social prescribing and health coaching to help with this kind of support, but the continuity is the thing that happens between those parts, and we found that helps to make them greater than their sum. We see that lots of different specialist services are being used, extensive amounts of resources, separate interventions, in many cases with little effect. The medical model by itself, we saw, wasn't meeting that person's need. And in line with that, we found that non-clinical interventions were really what made the difference and impacted greatly on the demand. We found that there was always a new intervention that made a difference, counterintuitively, even with people that we thought we knew really well. And I think they were the cases that really stood out for us when we see those heart sink patients that we expect to be constantly drawing demand on services, and we're maintaining them in that place. Actually, with a different approach, we've been able to see the change that Liz has talked about. The other thing that we found is that different organisational processes and policies can cause tension. When we're talking about shared decision making and personal decisions with people, sometimes what happens is that the person's wishes go against the clinical policy. So we start to wonder whether some of those policies that are in place to reduce risk can actually cause harm when we consider the individual instead of the rule. And then again, criteria-based systems are difficult to work with, both with the people that we're helping and the providers taking a tremendous amount of energy, which is pretty familiar territory, spending a lot of time taking to make the case for meeting the criteria. Not qualifying for an intervention might save an individual transactional cost, but it can often create additional costs across other parts of the system. So we start to ask, in the attempt to optimize those individual budgets, does the criteria in some cases that we put in place to save money actually cost the whole system more? And overall, the solutions that we put in place weren't sophisticated, but we saw a really big difference in the people that we're working with, much happier, more comfortable. And of course, Liz shared those stories with us as we went through the experiment, but we stopped at a point and said it's time to have a look at and see what difference that we made to the demand in the system. So we start to have a look at the intervention effect analysis. We had 22 people in the analysis. Doesn't seem like a lot. We did our best to free up the time for Liz to do this work, but we still needed to maintain her normal busy caseload and looking after 4 care homes. So the study is a sample only. It's not a study of what can be achieved in a year. And the intervention period that we looked at, measured from the time that we started work with someone until we did the analysis, was across those 22 patients between 2 months and 12 months individually, and the average being 5.8 months, just under 6 months working with them from the time of change. The costs that we applied to the analysis are typical headline demands on the system: A&E visits, ambulance services, hospital stays, 111 calls, out-of-office services and specialist services. The analysis that we based it on was data reports that we extracted from System 1 communications, because other sources weren't easily available to us. So we counted what we could readily count, just manually trawling through those the GP systems and studying them from before and after. Things like hospital stays, we based on non-elective admissions, so we didn't look at extended bed days. And we saw a case of one example of 153 days in hospital and transition care during their journey. So the numbers that we're looking at are fairly conservative. And we didn't go into detail of things like social care costs, GP costs, additional specialist services, new costs like care home, for example, or any of the associated reduced costs in care packages, benefits, allowances, and stuff. So the way we measured things was to look at a timeline and understand the change in demand by looking at the activity before our intervention and comparing that to the activity after the intervention. So what was the picture like before and after the plan that we put in place? We then used that information to extrapolate out to the comparative difference that we would make over 6, 12 and 24-month period. So we're using a timeline approach from the time we intervened and did something different. So when we looked at the results, we saw a profound difference. We didn't reduce the cost in all of the cases, but over a 12-month period, we see a reduction in these costs of 75%. So we're seeing things like 50 less A&E visits, 63 less ambulances, 52 less hospital stays. Really encouraging. We thought the calculator was broken and made sure we checked the numbers twice. What's really important to recognise is that we didn't set out to reduce demand. Our purpose was to meet the needs of the people, helping them to get what matters to them. And what we found is that what people want cost less and much less, and they're much better for it. And what this tells us importantly is that personalisation does pay if it's done right and given the time. It's not just a nice to have, and also this isn't new work. It's not a new role. It's working differently. So Liz is one of our most experienced care coordinators, been in the role for years, as she said. So the improvement is set on a backdrop of a mature service. Our care coordinators are already fundamental to the way we operate in all our practices. We haven't changed anything except for the behaviour of the care coordination in place at that one surgery. So in conclusion from the experiment, we found that from the perspective of the staff, it's been a profound personal transformation. It's really important to recognise the power of that normative learning experience, discovering and seeing things in a different way through experience. We heard things like, I can't unsee that now. I thought I knew them. I thought we were good at this. And having the time to work differently and seeing the results was really rewarding. From the perspective of the people that we helped, focusing on understanding them and designing to their needs with them led to personal solutions which were different from the care that could be provided from the current system. So there was always something new that we could offer that made an improvement and made them happier. And as we saw from the perspective of the cost, doing the right thing in accordance with those individual needs and what matters to them is quite simply more effective and more efficient.
Brilliant. Thank you, Darren. That's go. So you carry on.
Yeah, just got one more minute, and then I'll finish up. So those results are encouraging, and naturally we want to do more, but how we do it is really important. We don't want a specification or a blueprint to roll this out. That traditional rollout method of here's the answer, now do it, won't work. So it's evident that that to achieve the same results, we need to take others through that similar learning experience. And that involves studying the patient and the system from the person's perspective and applying that method in individual practices. We can't underestimate the difference between a logic model and the learning experience. The logic model really can give us a natural response of we're doing this already, which is kind of Liz's view when she started, and we're good at this, aren't we? And in fact, that was the very question that we came up against when we first did that study and stood around those first cases. We got that question is, yeah, we're good at this, aren't we? When we looked at the journey from a person's perspective, we agreed that the system wasn't meeting that purpose. So we set out to make change from that perspective, and that's the kind of understanding that we need and the kind of learning experience that's needed to change how we work. So that's going to be fundamental to how we roll that out, and the plan will be to repeat that exercise in each of our different practices as we continue to learn and refine as we go.
Brilliant. Thank you so much for that, unpacking that. So I think we'll just move straight on to questions because I want to have a chance to unpack this. Now, Katie Whitehead's popped a question. I wonder, Katie, would you be able to pop your microphone on and just maybe ask that question? Because a few people are seem to be keen on that question. That kind of
it was just that a lot of what you described sounds a lot like what myself and some of my colleagues have done in the past when we've had the additional funding available to take the time to do it, which is, taking that person-centered approach, asking what matters to the patient, having the time to have a really open two-way, patient-led conversation, and now we've got sort of health coordinators in the R's roles, and health care coordinators who are not necessarily from a nursing background, I was interested to hear that Liz is a nurse and health care coordinator. Is that, I'm not sure if I've got that right, which sounds like a really sort of skilled and specialized role. But I didn't quite understand the link between all the sort of theoretical stuff at the beginning and the models and the pathways and everything, and then it just jumped to something that I feel like, with enough time available, a lot of us have been trying to sort of have a go at over recent years. I just wanted to try and see the sort of link in the system and the sort of more clear model.
So I'll pick that up, and Chris, jump in if you like. We started with our care coordinators in our practices before the primary care networks came in those roles in the roles scheme. So we had people like Liz in those care coordination roles. So we've introduced care coordinators, of course, to support them through the roles scheme. But we had those care coordinators in place. And what we found is we've got a budget that's based on a capitation per practice to support that work, and we're becoming, I guess, a victim of our own success, and more cases and more demand coming through that. What we wanted to do is study the difference that we can make. So part of that is to understand what effects it has on demand across the system, so that we have a case for investing in more of that work. And then the model that we used is to help us change, help to see things differently, so that we can make the most of that work that we're doing. So that was the learning experience that we went through, taking the time to study individuals in real detail, that made a fundamental difference about the way we saw things.
Yeah, thanks.
But can I just say one thing to that, because I find it really interesting that it sounds a bit like from Katie's questions also, that when you have that time and when you have those resources, it's kind of a nice to have. Well, actually, what we've learned is that the benefit that you get from it, and that's what I think we've documented here with all the cost numbers, and not just that, but the effect of those lower costs on the patient's health. I mean, those lower costs is directly related to better health and patients that are doing better. So actually, that, the benefit you get from doing the right thing first. I know we've not changed the whole system yet, but it's opened up doors to kind of start digging into the bigger system and draw them into this same way of thinking, so that you can help even more patients and reduce costs even further.
Yeah, I would sort of say, from my point of view of having done having worked with the complex cases for a long time, what I carry on doing it in my day-to-day work now is working in this very different way. And I appreciate that, although it does take longer, unless we invest time to understand and make those difference and tailor the care from the patient's point of view and challenge the current systems, then we're never going to improve our workloads, because our workloads are going up and up and up week by week. But what I found was, when I get it right, that my time with those patients absolutely dramatically reduces. So I've got one guy that each month he would be having over 200 calls to various services, mental health chap, phoning out of hours, the police, ambulance, you name it, he would be calling them. And once I got to understand, and we built that rapport, and he had a high level of continuity with myself, and we got the care tailored to meet his needs, he no longer is using any systems, because he's getting the level of care, and I'm supporting and managing him without any other interventions. The occasional mental health CPM, we do joint visits when we have little blips and flare-ups, but on the whole, those 200 calls each month have gone down to nil. it has made a phenomenal difference, and my workload is reducing once I'm able to understand and work in a different way, which initially absolutely increases my workload, but over time it levels out.
Jim, there's a few people interested in your question. Jim Lyons, do you want to come and ask that?
Hello, so I am a Vanguard practitioner employed by Portsmouth City Council. I'm currently running an intervention with Hampshire and Isle of Wight Sexual Health Service. Just one of the headlines from our work is we're now quite a long way through rolling, and we've reduced the number of incoming calls to the system by 3,500 per month. So it's been a really successful piece of work just by eliminating so much failure demand. One of the key causes of failure demand in that system, there were many, but one of the key ones was the 48-hour contact to clinic target that was propagated by organisations like the British Association of Sexual Health and HIV, NICE and other national bodies. So we removed that target from the system. We found that it prevented us from absorbing variation. It created a de facto purpose, corrupted the motivation of the leaders, made them kind of extrinsically motivated, and spawned an incredible amount of failure demand. I was just wondering, given the fact that targets are so ubiquitous in the NHS, whether you encountered anything analogous to that.
I think with the cohort that we were looking at with the frail elderly, we didn't see targets creating the same dysfunctional, certainly not to the same degree. What we tend to see with the frail elderly, they were more keeping to themselves. If the system didn't provide to them what they really needed, they started to withdraw more and more. And then when crisis hits, they phones the emergency services and starts that whole cycle. And I think for us, that was the key bit in realizing that's what's happening, that actually a lot of people keep to themselves, get worse as a consequence of not getting the right care. And then when they get to crisis point, the system just throws, thousands of pounds after them to help them at that point.
Okay, so thank you.
It's different triggers, system triggers, I would say.
Thank you.
Yeah, that's where our interest has been, rather than targets. Understanding the triggers, so that we know when to act. So we took some cases randomly to start the experiment. As we studied further and looked at demand, we started to look at the triggers where we would respond, and getting those right.
Thank you.
The idea is to move from a model that we're talking about, containment, where we're working at the tail end, where we're seeing significant use of services. Now we can move that along to a more preventive view, but our focus has been on that containment space where we can demonstrate that difference pretty simply, because we're picking up at that case in that state in the journey.
Great. And I'll just pick up if there's a bit of a theme just around kind of pragmatically, perhaps, what this might be a question to Liz, if what could people start doing? How is this different to what you previously did? And if we were going to start doing this in our practices, where would you start? What would you do?
So for me, it's understanding not only from the clinical patient's journey, but also from their perspective, what do they want from us, and what can I do differently to get a different outcome? Because currently, if I carry on doing what we've always done, we're not going to make any difference to your healthcare. What is it that you want from me, and how can we work in a different way? Can I challenge the referral criteria, the policies, the services, to see if we can get a different outcome? And for me, that's been the biggest difference. Once I understand it from that patient's point of view, they'll go to the doctor. I had one lady kept going to the doctor for bunions, sore feet, we would prescribe, analgesia. We'd refer her to the podiatrist in the early days. All she wanted was her toenails cut in, but she knew that service of getting her free toenails cut in, she had to jump through the hoops to get the outcome she wanted. So for me, it's stripping back and actually what does the patient want from us? Because sometimes what we think the patient wants from us isn't what their agenda is. And it's trying to actually unpick what their agenda is so we can facilitate that without going around the houses for, because at the end of the day, most of our patients are quite creative and they know that if I don't get it from your GP, I'll phone out of hours, they'll give me that prescription. And if they don't give me it, then I'll call 999 or I'll rack up to A&E to get. So it's about understanding what their agenda is to really unpick what matters to them.
And how important is it to kind of go out to their house to do that, or could you invite them in? What would you do?
I mean, for my cohort of patients, so even those patients that aren't necessarily housebound, I've found it really useful either to engage with them at home to get that bigger picture and understand where they're coming from, their lifestyle, what matters to them, and ask them where they prefer to see me. Some patients want to see me in the surgery. Some patients want, one chap I met in the local pub. He wanted to meet me there, didn't want me at home. And it's just about me engaging and building up that rapport to over time understand what makes them tick. I have the privilege, I guess, of understanding their medical records, their medications. Some of my patients, we keep prescribing over time all these different medications, and then you go to their house, you open the cupboard, and out come, piles of medication, because they go to the doctor for one thing, but they've not really engaged with what really matters to them. They come out with another prescription and they don't tell the doctor that that's not really, because they don't feel they can, otherwise you might stop something. And there's that, so that level of continuity, building up that trust and really getting on their level has made the biggest difference, really.
And then how do you document what you've discovered, and what's the system that makes it that you end up being retaining that continuity when they ring up?
So for me personally, so I then on the front cover of the records, that if some of these high user patients keep phoning up, the surgery know to send them to me. So I've got one lady currently who's a mental health lady who keeps phoning the GPs every other day. She's convinced on whatever, and so now all the calls are diverted through to me, so she's getting that level of continuity. So we're not just repeating and keep referring her to different services. So I'm trying to work with her to gain an understanding what she really wants from the system and from us. So I've now dramatically reduced those calls to the GPs all the time, and the different ongoing referrals and the A&E, and I'm working with the ambulance crew so if she triggers an ambulance, we can then work together to try and support this lady in a way that she needs supporting, not the way the system feels she needs supporting.
Great. Yeah, and it's a remarkable story. It's really great to hear something done differently and the impact that's having, and it's going to challenge some of the ways that we work. We've reached 9 o'clock, so I think we can kind of call an official end. It'll be recorded, so potentially you could share this with colleagues if you think that would be helpful. I think a few of us would be happy to stay on for a little bit longer if we've still got questions that you want to ask, but if people want to leave, now would be a reasonable time for you to get on with the rest of your evening. I'm certainly going to stay on for another 15 minutes or so with anyone else who might want to. Sound reasonable, Matthew?
Yeah, happy to join you. I wouldn't mind picking up. I wouldn't mind picking up just on that starting point question. I think when we're looking at rolling into other practices, we're leading with that detailed study. because there's no replacing taking the time to go through and map out every transaction on that record, to stand back, and the value it offers by standing back and having a look at it with the partners in the practice to say this is what care for a person looks like across the whole system, and we can see where people have started and stopped and intervened, and what that means as a journey that you wouldn't otherwise see. So we've done that on a number of times, and each time it's been really, really eye-opening, and just the process of going through the records and reading the comms from I've sent someone here and this is the response and where that's gone to, and following that journey is a learning experience that can't really be gained in any other way than going through that exercise. And I think it's about the best day out that you can get from a learning experience. I think it beats anything off the shelf, going through that exercise and being inquisitive and shocked and amazed by what we can find by trawling that deep. I can remember coming in and seeing Liz and Chris after that first day, not knowing what to expect. I think Liz was a different person then already.
And do you think that that's important, not so much for that individual patient, but it's about the mindset shift of everyone actually seeing that and being like, okay, now I get it, and there's a
that's
penny
the
drop
learning
moment.
That's the learning. And I think, as Liz was saying, we go from a position of yes we do this, but actually studying and understanding and seeing that fit is profoundly different than any logic can apply. So that is, yes, it is. We wouldn't want to do that with every person that we're looking at, but actually that study is the learning that starts the experience for us to roll into the next practice, and everyone has signed up to go through that through that experience as we repeat it, because we don't see any other way of pulling that value from anywhere else in that starting understanding phase.
And just a quick note on that, just to add to it, Darren. I mean, it's a big part of the Vanguard method that I haven't mentioned. I've focused a lot on the system perspective and what problems you see when you take that, apply that perspective in practice. But really, what you need is to challenge your thinking and your assumptions about how to design and manage work in service organizations, and that's what we're trying to do by letting, I mean, it wouldn't help me showing up as a non-healthcare professional, showing up in Liz's office saying, Liz, let me tell you how to view the world. She would slap me and I would be out after 5 minutes. But when I said, Liz, let's have a look at the patients from a different point of view, let's try and understand them differently and take the time that it takes to do that. That's when you start challenging your own assumptions about how to carry out the work. And that really is the foundation for creating the kind of change that we're looking at here.
I think Lisa might have had a non-virtual hand up. Go on. Yeah, you're on mute at the moment.
You should better.
Yeah, Lisa, I'm not sure we can't hear you, but you're not on mute, so you can maybe pop it in the chat. Maybe you could write the question in.
Ben, can I jump in while you're waiting?
Yes, go.
So I put it in the chat before, but what we've been talking about here this evening is this idea that those very, very complex people, if we believe the 80-20 rule in that 20% of your patients take up 80% of your time, the kind of thing that you've done here is one end, isn't it? What I'm also interested in is, and I put about repeat prescribing system, and I'm really interested in Kristian's view as to whether or not anybody from Vanguard has actually tried to map the beast that is the repeat prescription system, because as a pharmacist who ends up doing the bit now at the end, which is a bit like what Liz is doing, which is now called a structured medication review, where if you've got the right skills and you've got the patient on board, you end up unpicking all the stuff like Liz has just described, but all to do with medicines. But I'm absolutely convinced, and there's a group starting on this tomorrow for the National Overprescribing Review, that the repeat prescription system drives a huge amount of failure demand.
Absolutely.
I think, yeah, so we haven't dealt with that, unfortunately, but we've certainly learned about the negative effects of it from when we've been studying the patients. Medication in itself is a huge topic that kind of goes across so many patients. It's definitely something that we would like to get our teeth stuck into, but we haven't redesigned that yet, unfortunately. But I completely agree with you. It is generating huge amounts of failure demand. Just the whole, I mean, we've been looking a lot at, you know, are the patients that we've been looking at, are they getting the right medication? Are they taking it themselves? I mean, often we, you know, Liz, you've been showing me pictures of these, what do you call them, with all the, you know, day 1, 2, 3, 4, 5, you know, yeah, all that stuff. And they've not been touched, you know, they've been picking here and there, you know, so we're prescribing all this medication and it just ends up in a local inventory at Mrs. Whatever. And of course that's a huge problem, because then that person goes into the GP and say, I'm sore here or there, and we assume that they take the medications, but they might not even know that they're not doing it correctly. So it's a huge contentious issue, creating loads of waste and failure demand, absolutely. But I don't think we've fixed it. I think, Liz, you've fixed it for the people that
I was going to say for I would say about 80% of my patients, I end up bringing back bagfuls of medications that they absolutely don't take, don't know what they're for, but haven't dared tell anyone. For some reason, the carers don't seem to tell the doctors or the pharmacists that they're not used, and there's huge waste that I'm trying to unpick, and I do those, you know, for me, doing the medication reviews in the surgery face to face with some of these complex patients is not the answer. We need to be doing them in the patients' homes to unpick and understand from their point of view, because they'll tell you over the phone that they're taking them and they're doing everything and they know what they're for, but when you challenge them in their own home and you go, you know, you ask them where they keep their medication, it's just horrific, the amount of waste. Horrific. Yeah.
Jared, do you want to come in?
Yeah, thanks. I'm zooming in on a particular aspect. I think somebody else raised it, but you know, we've seen it multiple times. The effect of, you know, 10-minute slots or 15-minute slots in social services, you know, sort of mitigates or prevents any kind of deep understanding, you know, at the get-go. And I'm just really interested to hear how in your practices you've whether that's an issue, and if it is, how you've been able to redesign appointments. So sometimes people need a lot of time, and obviously, you know, that changes the nature of your day, and can affect your ability to meet with others. So just really interested to hear what your experience has been.
So
yeah,
again, oh yeah, so I guess from the point of view of obviously appointments, what we found was, you know, we say we haven't got the resources in the NHS, but that absolutely is not the case. What we've got is the resources that are being used inappropriately because of these failures, really. So when we say we've got 10 minutes to deal with a patient, I guess we use a slightly different system in Lincolnshire with Ask My GP. So we don't have necessarily those 10-minute appointments where you're able to give a little bit longer. And if we've got those patients that we know, if we're not going to get on top of the root cause problems, we know all those patients that are going to be here again tomorrow, that are going to phone up the next day, that are going to phone up next week. So it's about investing time. If you know this person is going to phone you every day, at some point you're going to have to set some time to start to understand and get to know this patient, because over the week, over the month, that patient is going to use up your time. and we found once I was able to invest, and it may be that you know, if it's not your GP, or whether it is a care coordinator or somebody else that can take ownership and try to understand what matters to that patient. Because I found that sometimes it's not necessarily myself that was needed to understand, but the neighbourhood care coordinator, a band 4, if she was able to engage and spend and have that continuity, and build that trust up, that made the biggest difference for that patient to understand their medication, to get the right services or social prescribing and get links into, as opposed to just falling to the GP to sort out all the time.
Yeah, we did a study as well through the Ask My GP consulting online consulting platform, to have a look at the demand through that, which is a different cohort than sits on Liz's caseload. But what we said is, you know, we're looking at frailty and understanding that. Let's have a look at the transactions that are going through that system. It's a transaction work plan system that actually does drive more of that behavior. It's a tool to manage a workflow. So it's tricky to get it right, isn't it, between the people that do need a 10-minute or a 5-minute or a quick message of support, and the ones that need more. So we did, you know, there's different ways of looking at that demand. What we see is a transactional demand, and we can say these are the top, and it was flabbergasted the number of people, the small number of people that took up such a high percentage of our demand. I think we saw something like 40 or 50 people taking up 5% of the demand at the front end. And so we don't know what the nature of that demand is through the system, but we started to study that. So we reach out to those people, have a look in the same kind of way, understand and see if we can put something in place that's different. You know, we're a little way off yet on a system to recognize that inflow, but we've started to have a look and get interested in studying from that perspective. And what we found again is that, you know, it's a different cohort, but we certainly found some similarities of the people that were in that space. So it's worth investigating. We're going to look at it at closer, studying that transactional demand, what it looks like, who's driving that, and how we can pick it up and work differently. And again, it's investing a different kind of time where it's needed to save time overall from the repeated transactions that we see. So yeah, definitely interesting and different space, but similar method, of course, can be applied.
Great.
So one of our practices is interested in picking that up in detail, and we had the discussion and decided, well, the best way to start is the way we started with Liz. Well, let's take one and study it in that detail, and then work, you know, and then work from there. What does that tell us? What does it look like? What can we understand? How can we apply that to more? So we're using the same. We're looking using the same method for that in a different cohort.
Great. I think probably we should wind things up now, because I don't want to flog our speakers for any longer. But really appreciate you taking the time to come and share this. I guess I'd just be curious to know what if people want to know more, they've got unanswered questions. What's the best way to follow this up?
Happy for you to share our contact details. If you're sharing the slide or the presentation, happy for you to share those.
Yeah, so we'll email afterwards the slides, the recording to everyone, and maybe we can include the contact details there. And you can join this the primary care special interest group if you want to kind of put questions there as well and discuss things. We'll put a link for that in the email. Yeah.
Great. All right. Thanks, everyone.
Thank you for inviting us.
No, thanks for coming.